everybody. I'm Judith Chure from West University. You probably met me in the last 4 days. First, I'd like to say how great these 4 days were, and I was so excited to welcome you in Budapest, and I hope you enjoyed our scientific program, our networking programs. And now I'm a little bit sad to announce that we start our very last plenary lecture for SMRA 2025. Which will be very exciting. Let me introduce my co-moderator, Mitsuya Miyazaki from University of California, San Diego. And I'd like to ask the first speaker to give the Sadamoto lecture, Paul Finn, the evolving landscape of contrast-enhanced MRA. Paul Finn is from University of California, Los Angeles. Thanks, Paul.
Thank you, Judith. And it's a great pleasure to be here. This is my first visit to Hungary and to Budapest, and it's just stunningly beautiful. So thank you for doing a great job on the meeting and for organizing this. I need to be pretty aware of time. The moderators have been running a very tight ship. And my slide isn't advancing, so that's not a great sign. Let's see. Okay, sorry about that. So yes, my talk is going to focus on what I call the evolving landscape of contrast-enhanced MRA. We've all heard a huge amount about non-contrast enhanced MRA and contrast-enhanced MRA during the meeting so far. So some of what I say will be just a snapshot of what's happened, but later on I'll talk based largely on my experience and the experience of others about work with ferumoxytol, which I think will have a large role to play down the road. So what contrast agents are we talking about currently? Well, basically, most of them are the extracellular gadolinium-based contrast agents. And the other broad group is represented by ferumoxytol as a blood pool agent. And again, here's a summary slide, quite a busy slide with a lot of information, which I won't go into. It summarizes the currently available approved gadolinium agents. And nowadays, we're really focusing on the macrocyclic agents. And most recently, with the introduction of gadopiclinol as a high-resolution extracellular macrocyclic, this has enabled significant contrast dose reduction. And also, another agent that's currently under FDA review in the US is gadoquatrane from Bayer, and we heard from Giles Roditi about the early experience with this, and it's very effective in lowering dosage. And lowering gadolinium dosage has been a goal for some time. In the past, we've managed to to lower dose sometimes by a factor of 3, without much difference in the appearance of the images, both for peripheral arteries and carotids and for other vessels throughout the body. And again, this is excerpted from a recent paper from the Wisconsin group describing the use of gadopiclinol, where basically they found it was equivalent at half the dosage to gadobutrol. So again, that's pretty exciting. And Giles Roditi presented similar work recently with gadoquatrane. Meanwhile, experience has been growing with the use of ferumoxytol. We all sort of know about it at this point. It's approved in the US for intravenous iron therapy, not as a diagnostic agent. So its diagnostic use is off-label. But at this point, we've had more than 10 years experience with the off-label use of ferumoxytol for MRI. And it's also undergoing clinical trials right now in China, both for MRI and for therapy. So things are kind of exciting. Here are a few examples. This is a tiny dose of ferumoxytol used for first pass imaging of the calves. The images on the left and the right are simply volume rendered reconstructions of one specific phase of enhancement. But again, it produces a similar pattern to first pass gadolinium. And here, a different patient, again, the right and middle panels show small dose twist, basically first pass MRA of the calves and the thighs. And then with a full dose, you can basically image everything else in the body. This is a patient with a renal transplant, which we can see here beautifully. Another large indication for ferumoxytol has been patients with renal impairment. We've looked at a lot of patients with renal transplants. Here's an example. This patient has complete occlusion of the common and external iliac artery here and stenosis of the left, but a widely patent transplant renal artery and vein. This is steady state imaging. Here's the corresponding contrast angiogram confirming all of those findings. Patient underwent bilateral iliac stents, and the same patient developed claudication. So this is ferumoxytol first pass showing occlusion of the left anterior tibial, and again, perfect correlation with the angiogram. Another set of vulnerable patients in whom ferumoxytol has been shown to be very useful is in pregnant patients. Ferumoxytol is safe and sometimes even desirable in pregnancy because it's an iron supplement. And the Wisconsin group has done a lot of work in looking at patients with suspected pulmonary embolism in pregnancy. And this is a recent paper from MRA in 2023 from that group. Basically, there's not much you cannot image with ferumoxytol. It's very powerful for looking at aneurysms. The image on the left here is just a bright blood standard MRA showing this huge abdominal aneurysm with thrombus. And these are single shot haste images with no black blood prep pulses. The black blood comes for free with ferumoxytol, and it's usually perfect. There's no residual signal on the T2 weighted images with ferumoxytol on board. And here's that same patient, volume rendered reconstruction. This was an 83-year-old female. So we can see the entire complex aneurysm in 2 breath holds. Basically, the whole thing was done in 3 minutes. For venography, because it's a blood pool agent, there's no hiding from ferumoxytol. There's a patient with central venous occlusion and all of these collaterals, again, a single breath hold. And one of the strengths of ferumoxytol is it can be used for multidimensional imaging. In fact, it has supported some really powerful techniques. We've been using this 4-dimensional music technique in children for about 10 years now. It never fails. We do them under anesthesia with controlled ventilation as a kind of a general solution. And again, these 4-dimensional images can be reconstructed into any plane. And we can get accurate measurements. Whoops. This doesn't look too promising. All right, that's a bit better. And at the same time, it supports 4D flow in much the same way because it boosts the signal and it really increases the signal to noise and the VNR for 4D flow beautifully. This again is done in that same patient, 2-year-old with complex congenital heart disease. I don't have the time to go into the details, but you can basically see everything and define all of the flow and all of the anatomy. And there have been some more sophisticated developments in this area. This is from Matthias Stuber's group, where they're describing the 5D free running framework, which does respiratory as well as cardiac resolved images. And this also is with ferumoxytol in the steady state. And our group, under the direction of Anthony Christodoulou, have developed related type, but different class of techniques using multitasking or low-rank tensor reconstruction on these sorts of same patients, because it's desirable to be able to do these techniques free breathing, not just under anesthesia with controlled ventilation. The trouble is, in adults and in older children, typically we can't control their breathing pattern very well. So we have to fall in with these very advanced approaches, which are increasingly very good, but maybe not perfect. One way to try and solve the respiratory motion problem is to do this in a breath hold. So we've been working on techniques to develop breath hold 4D or 4D music imaging, and we've made some progress. This is, without going into too many details, we can discuss it afterwards, single breath hold in a 29-year-old female with tetralogy of Fallot. And this is with 10 phases in 21 seconds. This is a 13-year-old child, again, repaired tetralogy of Fallot, single breath hold, 10 cardiac phases, and in the same child, a different breath hold, this time with 24 cardiac phases and a 35 millisecond temporal resolution. So this is sort of single breath hold, 4D imaging, and we can quantify ventricular volumes and function and so forth in the steady state distribution of ferumoxytol. This is a 65-year-old female with corrected transposition of the great arteries. Again, a single breath hold that shows everything. And this is 22 phases in about a 20-second breath hold at 1.5 T. Now, that patient I showed earlier on with the occluded right iliac artery and the renal transplant, this is the same patient who came back to us a week ago for a follow-up imaging, but also with some suspected thoracic aortic problems. He has dreadful vascular disease throughout the thorax and abdomen with all this irregular plaque, but no evidence of dissection. And again, this is done in a single breath hold, multi-phase. We're sent for MRA, not cardiac MRI, but with another breath hold, we get the entire heart for functional imaging. And we've got ejection fractions and volumes as a sort of a very quick add-on. And of course, his transplant renal artery and vein are fine years later. So it's amazing how many of these patients who are real vasculopaths just keep on trucking, and this patient is doing very well. Another thing we shouldn't forget about is that we're not necessarily looking at exclusively gadolinium or exclusively ferumoxytol. They can be used in combination. This is a patient with an ICD in place, and the top row shows delayed enhancement imaging with the wideband technique developed by Peng Hu at UCLA. And in the bottom is just a spoil gradient echo flash imaging, cine, but with fairly much perfect image quality. So there's no longer any loss of quality because we can use flash, which is very insensitive to off-resonance artifacts, and the ferumoxytol keeps the blood signal nice and bright. And here's a pediatric patient with a cardiac tumor. There's this very large mass here in the right ventricle. The top row shows the situation after ferumoxytol alone, and there's very little enhancement in the tumor. Then we give gadolinium and repeat it. Now you'll see all this enhancing tumor. So basically, this is the difference between the blood pool and the extracellular fluid space. Here's the same child with some volume rendered reconstruction. This is the tumor. This is a haste image showing the thymus and the tumor. And here you can see, obviously, the tumor, but the ferumoxytol shows the context, all of the cardiac chambers and blood vessels in relationship to the tumor. So here we have everything. I think this is very much an unexplored area that has huge potential. And also, we don't have to look at exclusively one modality, which we tend to do at the moment. We can combine the best of CT and MRI, for example. In this patient who had renal failure, he also had non-contrast CT, patient with congenital heart disease, and ferumoxytol in the steady state. So all of the blood vessels are derived from the ferumoxytol data, but also he's got an aortic valve prosthesis, which we'll see here. And that's courtesy of the CT. You can't get an image like that of a valve with MRI. It's trivial with CT. So why not stick them together? It's the same patient. And here we've basically outlined every vascular bed: arterial, venous, systemic, and pulmonary. Okay. So in conclusion, contrast MRA is a highly dynamic and evolving field. The new high relaxivity, that shouldn't be relativity, I guess, high relaxivity macrocyclic gadolinium agents hold promise for dose reduction. And experience with ferumoxytol continues to grow and the applications expand. I'd just like to make people aware that at ISMRM, we formed a new study group on MRI contrast agents. And the short-term focus will be on comparative and complementary clinical applications of the newer gadolinium agents and non-GAD agents. So please, if you're a member of ISMRM, please join the study group. Thank you for your attention.
Thank you. Next speaker, Chuck DeMolin, neonatal MRI, past, present, and future. He's from Cincinnati Children's Hospital.
I'd like to thank the organizers for inviting me to present this this topic this morning. How do I advance? That button, not that button, that button. Okay. These are my disclosures. So the talk I want to present this morning, I want to cover a number of topics. Just ask the basic question: why do we want to do MR for neonates? And a fundamental question: should we bring babies to the MRI system? Should we bring MRI to the babies? I want to also go over a little bit of early work that has taken place over the last few decades in NICU MRI. Talk about the current landscape, and then talk about some of the future opportunities and ways that NICU MRI can evolve and develop. So the first question: why? Why do we even bother to think about MR for neonates? Well, there are over 4 million babies born each year in the United States alone. 12% of those babies are premature. Any of those babies, most of those babies, spend time in the NICU. Stays in the NICU are quite expensive, or can be, up to $6,500 per day, and the average stay can be as long as 40 days. Now, MR is, of course, viewed to be a very expensive modality, but when you put it in perspective with those numbers for the NICU stay, all right, it's pretty inexpensive, actually. And MR does provide some unparalleled ability to provide the medical guidance needed to manage these babies. So it's we all know and love MR, but it's just not there. That's not what is the imaging modality that is used routinely in the NICU. The imaging modalities that are used are typically going to be ultrasound and X-ray. These babies deserve better. If you look at the clinical challenges that these babies face in the NICU, they're across the entire body: neuropulmonary, abdominal applications. Some mirror what goes on in adult medicine, but some are very unique to these babies. But pretty much every sort of body part is involved, some aspect of neonatal challenges, perhaps except for sports medicine type injuries. We don't have a great need to image knees and premature babies. So why isn't it routine? Well, the adult systems that we have today are just not really well suited for these babies. There are major risks associated with where the scanners are, how loud they are, and how poorly behaved the coils are in these scanners. So the scanners that exist today just are not up to the task. Furthermore, the NICUs tend to be in different parts of the hospital. They're isolated units. They really are there to protect the patients. We don't really want to have patients coming out of that unit, going through the hospital, being exposed to noise, vibration, infection risks, and so on. But perhaps the biggest reason we don't use MR today is that the major vendors in MR today have really not paid attention to this market. It's viewed as just too small of a market for them to put any effort into, and so the products are just not. But nevertheless, put that issue aside. Should we be bringing these babies into the MRI system, or should we be bringing MR to the babies? Many years ago, my group and I developed an MR-compatible incubator. If you take a look underneath this incubator up here, see an MR table, but we basically made this system to transport babies down to the NICU. It was used for many years at UCSF. And it really answered a number of fundamental questions. It was used with spectroscopy, diffusion-weighted imaging, just all sorts of other imaging. And it really showed that MR does have value in treating and managing premature babies. It also showed, of course, that MR is an excellent research tool. I mean, these topics obvious to everybody in this room. The result of all that work, though, was actually never, the most important result of that work was never published, and that is real challenges are logistical, getting the babies out of the NICU into the scanner and then back. And in the workflow that was done at UCSF at that time, it took a total of about 7 hours to do an MR scan, and it, bed to bed. And it also took about 3 or 4 staff members out of the NICU to ride with one baby. So I think the conclusion is obvious that we do need to figure a way to bring MR to the babies. This was a conclusion reached by a number of groups. So that some of the earliest work was done at Hammersmith Hospital in England. And then more recently, we've seen the introduction of scanners that have been built expressly for babies. We started at Cincinnati Children's about 15 years ago to pursue our vision of this, and the vision was to really to improve outcomes in the NICU, and to do that by designing a system expressly for these babies. And so we developed this small footprint MRI system. It has served over 1,700 patients and resulted in a large number of applications or publications. Some of the lessons we've learned from that is that MR has basically a better track record in diagnosing bleeds. Ultrasound frequently misses or undercalls a bleed or overcalls a bleed. Also, MR is much more successful than X-ray for revealing details in, for example, the severity of bronchopulmonary dysplasia in these patients. It's much easier to see and quantify these sorts of diseases. Clearly, MR has a tremendous capability to look at small bleeds in the brain, but also devastating large bleeds in these patients, and provide objective and quantitative information about the status of disease. MR angiography has also played a role. We have a number of babies, of course, have congenital malformations of various types. So you can see the quality of the MR angiography here is quite nice. And it also has a big role to play in pulmonary systems, where we have babies who have perhaps underdeveloped lungs due to congenital diaphragmatic hernias and so on. We've also used the system to look at the great vessels for vascular malformations, using all the tricks that all of you are familiar I want to really point out, though, one last case here with this system, and that was that this is a baby that had a prenatal surgery to repair a diaphragmatic hernia, was on 100% oxygen. Its pulse ox numbers were very, very low. The neonatologists were at the point of having to decide, is this a case where we have a withdrawal repair situation? The baby ended up going into the MR scanner, and if you look closely at how the diaphragm is moving, it's rocking back and forth. Now, this baby was spending a tremendous amount of energy pushing air from one lung to the other rather than in and out. When this was shown to the surgeons, a surgical repair was made, and this baby went on to have a very good outcome. This is a baby that almost had the plug pulled on it. So that's one of the real values of MR. So we learned a number of things. One is that there are huge advantages for going small. These scanners, because they're small, they're quieter. They have a much higher peripheral nerve stimulation threshold. There is a much lower risk when you put the scanner inside of the NICU. You don't transport the patients in and out and so on. We also learned that 3T is probably a better field than 1.5T for these babies. The bore size we had was a little bit limiting, and of course, it's important to have the right coils and so on. All right, so what is the current landscape today? Well, it turns out we're in a funny period of time. We have a number of small companies that have brought out products that are targeting, either directly or indirectly, the neonatal patient. They range from very, very low field, such as the hyperfine swoop, the aspect embrace, which is a 1 Tesla system, is actually installed in a number of hospitals now. And then we have other vendors bringing in 1.5T and then also a 3T product. The 3T system is made by a company called IS Medical Imaging. We have a research prototype of that unit at Cincinnati Children's. Tesla magnet, 24 centimeter field of view. Very powerful gradients. One of the things you can do when you go small is you can really push the gradient performance quite well. It has Philips electronics in the back end and so on. Resolution is going to be very important in these patients. And so one of the nice things about going to a higher field and stronger gradients is you can really push the limits like you're going to need with these babies. So this is a 22 centimeter field of view with a voxel size of 0.2 by 0.2 by 3 millimeters. So you can see the resolution on the system is going to be quite good. The scanner has been now just starting its first clinical use. So here's some examples of T2 weighted and T1 flare type imaging. So all the imaging you would expect. Looks like an adult head, but in fact, keep in mind, this is from a premature baby. Also use the scanner to make very nice cardiac images and also diagnostic images of the brain, in this case revealing some hidden or sort of not clinically significant microbleeds. But even though they're not clinically significant, they may be significant from a developmental point of view. And this is one of the powers that MR is going to bring to these patients, is helping to really give these babies the best trajectory for the rest of their lives. Here's some examples of time of flight MR angiography acquired with the system. All right, so what's the future like? There are some questions that NICU MRI are going to have to answer. What is going to be the imaging mix? The conventional wisdom is it's going to have be dominated by neuro. And I think that to some extent that might be right, but I think also that there are going to be a huge number of applications in the chest, especially in the pulmonary system, because a lot of babies in the NICU do have pulmonary issues. Clearly, angiography, cardiac imaging is going to be important, spectroscopy important, maybe even interventions will be important. There are certainly going to be questions on who's going to run the scanner, who's going to own them, how they're going to operate. In many ways, it's going to be like MR as we know it, but in many ways, it's going to be different from what we have. Clearly, there are going to be a lot of clinical improvements that are going to come from using MR in the suite. And I think one of the questions that I think is going to be very important to answer is, finally, with MR, we're going to be able to learn how many babies we send home from the NICU with hidden pathology. Our rough anecdotal guess at Cincinnati Children's is that it's probably around 12 to 20% babies go home with some sort of hidden injury that we just don't know anything about. Another thing that might be different is that this modality of NICU MRI may end up being more of a screening tool than a diagnostic tool, the way we use and routinely think about MR. It is possible that in the future, we will have a situation where every baby who goes into the NICU gets an MR scan to get a baseline image. Every baby discharged from the NICU has an MR scan to understand the status of the baby as it goes out. All right, so wrapping up, what does a NICU system have to do? Well, it has to certainly accommodate life-supporting measures that are common in the neonatal care. These babies quite often come into MR scanning with being intubated or tremendous number of IV lines, infusion pumps, all those sorts of things. So clearly you got to be able to do scanning in that environment. It's got to be very fast, it's got to be quiet, and it's got to be easily installed on the upper floors where these NICUs typically are. And it really needs to provide the full spectrum of MR capabilities because there are going to be applications in the head, the chest, the abdomen, all over the place. And because our patients are small, you have to have very, very high resolution. And then from an applications point of view, I think that there's scenarios where you can sort of anticipate that spectroscopy and fMRI are going to play a fairly strong and those patients. Fundamentally, these NICU systems have to be designed for the patients, because we really don't take, we're not serving the patient well if we put these babies in a full-size, adult-size magnet. And then, so what will NICU look like, NICU MRI look like in the future? Well, some parts will be similar to what we're used to seeing, but other parts will be very different. There are going to be very, very few outpatients. This is an inpatient critical care system. The spectrum of diseases is going to be different than in the adult setting, so we have to be able to accommodate that. We have to depend on pediatric radiologists because these images do look very different than adult images. Screening may become important. Clearly, reduction of acoustic noise and sighting for the baby is really, really important as well. And finally, I think it's going to open up all sorts of new applications, things that we don't anticipate today. In many ways, today, the state of NICU MRI feels like very, very early days of MRI itself, where we had a new technology and it just went off in many different directions. People couldn't anticipate in the early 1980s where we are or where we have arrived today. All right, so is NICU MRI going to have a role in neonatal medicine? Yeah, I think the answer is yes, but only if it can provide better clinical value than current practice, and I believe it will. Thank you very much for your attention.
Wonderful. Thank you so much, Chuck. And I'd like to ask Giles Rodity to give SMRA 2025's last scientific talk on linking MRA across borders and modalities, global interdisciplinary collaborations to meet clinical demands. Thank you.
Thank you. Good thing I'm among friends. Judith just said it was the last scientific presentation, but this is not scientific at all, and it is not my title. I wasn't sure what to say for this title, to be honest, and just one disclosure here, this is my 26th consecutive MR Angio Club SMRA meeting, which I was amazed to work out, in fact. I gave a talk at the beginning of this 4 days on the history and future directions of contrast-enhanced MRA, and I suppose this is history and future directions of the Society of MRA, looking into the crystal ball as to what the Society is going to do in the future. This is our mission statement, which is on our website. We're an international group, and we're trying to improve patient care. This is said to be the first photograph of wildlife. I'm quite into wildlife photography, but it wasn't actually wildlife photography. If you don't know, This was a stuffed deer that the photographer took into the woods and did a 20-minute exposure. We think it was about 20-minute exposure. And this was the first X-ray in a hospital in the world of a patient with a problem. And this was done in Glasgow Royal Infirmary in 1896 by John McIntyre. It's a child who'd swallowed a penny and got stuck. And that probably took about 20 minutes as well. But the X-ray machines of the old days have given way to things that are different today, just like our cameras are different. And I can take pictures of real deer in woodlands, and I can take pictures of deer running across the moors, and they're running fast because I've got a fast telephoto lens. An MRI and MRA has evolved very, very quickly from the 1980s, 1990s to now time-resolved MRA, which happens in breath holds or less than a second. And CT, as we've also heard, someone in one of the early sessions said that this is becoming a bit like the cardiac CT meeting in some ways. We were having a lot of cardiac CT shown in some of the sessions. And we can get exquisite images of the coronary arteries in just a single heartbeat nowadays with modern scanners. So we've got up-to-date imaging of the cardiovascular system. And I just wanted to show another picture. This is a picture, you probably all know this picture. It's called Earthrise. And some people say it's the most influential environmental photograph ever taken. And it was taken by the crew of Apollo 8 in 1968. And unfortunately, the last of that crew died just earlier this month. Jim Lovell died on the 7th of August. The picture was actually taken by William Anders, who died last year. But it reminds us that we live on this blue marble. There is no planet B. We live on something that looks like this from space. And this is NASA call this the blue marble image. This is taken from multiple satellite photographs, taking away all the clouds, so we can see the Earth as it looks from space. And as you can see, the Earth from space doesn't have anything like what we see in maps. In maps of the world, geopolitical maps, we see all the borders that delineate the different countries, and we make these distinctions that aren't really there, to be honest, between different countries. And we also distort these countries. This kind of mapping is actually now becoming quite controversial. On this map, this Mercator projection, you can see Greenland at the top there, looks bigger than Africa. But Africa is 4.5 times the size of Greenland, and that's because the maps distort this. And I think this is why some people have become kind of obsessed with Greenland recently. They think it's enormous. They think Russia is enormous as well, because the Mercator mapping actually distorts what's at the north and south poles and makes things look much bigger than they are. I mean, look at the size of Antarctica on this Mercator projection. If you take away these distortions, and this is another map with distortions, this is where the MR Angio Club, becoming the SMRA, has been since 1989. These are all the places it has visited across the planet, across the blue marble. But this is the Mercator projection, and this is the equal Earth projection. This is showing you actually the distortions that are produced here and how Russia and Canada and Greenland and Antarctica are really much exaggerated in what we commonly perceive in our normal mapping. This is an equal Earth projection. This is from 2018, and there is a move to try and make this the standard. Particularly African countries want this. And I've put on here all the places that SMRA and MR Angio have been. And you can see on this equal Earth projection that we've not been to that many places. Though we're a pioneering group at the SMRA. We went to Cape Town a few years ago, and ISMRM is now going to Cape Town. We went to Santiago last year, and SCMR is now going to South America for the first time. So where the SMRA goes, larger organizations follow. Currently, we're in Budapest, which is somewhere here. My mapping's not great, but somewhere where this big pin lands in the continent of Europe is Budapest. This is the only AI-generated image. This is what AI thinks I look like as a pilgrim. Because I think when I go on the SMRA, it's like a pilgrimage to this kind of holy place where I learn stuff about that I'm interested in. And research has shown that people who go on pilgrimages, walks, they enjoy biological, psychological, social, and spiritual therapeutic benefits. And I think that's what I get out of coming here 26 times over the years. And we've come to Budapest. If we'd have pilgrimaged to Budapest in 1758, when this map was drawn, we'd have found a small city surrounded by a wall. And the Pest medieval city wall that is no longer exists. There's none of it. It was about just over 2 kilometers long. It was 6 meters high, 2 meters wide, and a battlement on top. Didn't stop the Turks invading and taking it over for 150 years. It was finally demolished in 1808. And if you go into the Mercure Hotel car park, apparently there's a bit of it down there, but that's about all that actually exists. Judith's maybe seen more of it. I don't know. So what is Budapest? Buda plus pest, this is maths, by the way, this is very complicated maths. Buda plus pest equals Budapest. It was united in 1873, but how did you unite? How do you unite two cities? How do you do it? What's the answer to that? So that answer is in fact probably the chain bridge. This was designed by an English engineer, and a Scottish engineer built it. And it was opened in 1849, and that allowed the cities on either side of the very wide Danube, it's a big river as you've seen, to become one city and to thrive beyond that city wall. This chain bridge was actually destroyed by the Germans in 1945 during the Second World War, when the city then became divided again, not before they'd done some other terrible things in this wonderful city. But it was rebuilt as we see it today, and Budapest is now flourishing, and it's a beautiful city, and partly because of the bridges that link the two sides across. So I think the message is that we should be building bridges and not walls. Sorry to be a bit political there. Turf is another interesting thing. This is my garden, looking out from my kitchen, and we've got a lot of turf, a lot of greenery there. Sigmund Freud coined the aphorism, the narcissism of small differences, which is probably explains an awful lot of ethno-nationalist conflicts. There's a lot of conflict in the world at the minute. If you look at them from afar away, you wonder why these people are fighting, because they look the same. We had terrible troubles in Northern Ireland for many years, and you go to Northern Ireland and I can't tell one person from another as to what they come from. We have the same in medicine. We have myths about our colleagues in medicine, such as the myths that cardiologists cannot deal with the lungs when they're looking at images, and only radiologists can see the lungs. James Moon is a cardiologist, a professor of cardiology, UCL, clinical director of the Barts Health Centre. His very first publication was on bronchiolitis interstitial lung disease, and he coined the term smoking-related interstitial lung disease. And he published this with a radiologist, the doyen of high-resolution CT, David Hansel. And it is a real phenomenon, this cardiologists versus radiologists, MRI physicists versus MRI engineers, and all versus each other, all with different ideas of what should be going on in the world. But in fact, they have a lot more in common than you think. And when we put these people together, we have the SMRA bringing them together and having conversations together. And the success of the MRA, I think, is partly the fact we don't have parallel sessions. So we have all sorts of disciplines in every part, but we also have these fantastic social events like we've had in Budapest over the last few days, and making the meeting a really good success, I think. We do have more in common with each other. This is Jo Cox, and she used this phrase in her maiden speech in the House of Commons in 2015. She was sadly murdered for her beliefs in 2016, but her sister has since been subsequently elected to her constituency. And it also applies to modalities. So this is, we've seen these pictures before, but this is MR and CT starting to look like each other. And the kind of stuff that Paul Finn is doing with ferumoxytol is making MR, push button easy to acquire like CT, and making it look like CT in some respects. And CT is coming to look like MR. This is the first MRA I attended, which was run by Philippe Douek in Lyon in 2000. But I didn't notice at the time, but Philippe's really quite a visionary, because prior to the MR angio workshop, he held the first international workshop on coronary angiography using MR and CT angio. So we have a long history of actually looking at coronary CT in this thing. TURF also applies to this kind of thing, which is really difficult for those of us outside our discipline. We know a lot of these acronyms mean, but for the average radiologist, let alone the average physician, they've got no idea what all these things mean. And we can think of many things like twists versus tricks, sense versus grappa. We don't have proper standardization of what we talk about in MRA. And we need to build bridges, not walls, between our vendors and across things, so we talk the same way, and hopefully in our things talk about things. You know, we see green grass, we can call it green grass, and everyone knows that it's green grass, and that it's not a gradient record acquisition in steady state. If I look from my kitchen window, I can take pictures of the mountains in a different distance, but it's quite difficult if I don't go out. If I go out over the field, there's a field behind me, and if I go out into the field and I walk over and go past those trees, then I find that the picture actually gets a lot better, and I can see what's further beyond. And I think maybe rather than being pilgrims in this society, we maybe need to become more missionaries, taking out what we do to other places and spreading the gospel, as it were. Because if I walk beyond those trees, then I can see this kind of view in the winter rather than just sort of peering over the treetops and just seeing the tops of the mountains. So next year, our missionary, if you are willing to accept it, our missionary statement is to go to Xi'an and see the walls in Xi'an. Actually, they still have a lot of walls in that city. So we'll see what we get up to next year. So thank you for that.
Please come to the podium for the three speakers, so we will have a discussion. Anyone have a question from the floor?
Maybe for Chuck to start, really impressive program there, the NICU imaging. At Mayo, we have a smaller footprint that Tim Liners helped us stand up with Kelly Horst for fetal imaging. I'm curious if you have a fetal imaging program, and that also kind of dovetails with what you guys have been able to build in the NICU.
Yes, our hospital does have a very strong fetal imaging program. We have a fetal care center that is physically adjacent to the NICU. We're not a birthing hospital, but births are performed there that are challenged or problematical. And actually, the very youngest patient we've scanned so far in the NICU has actually been only 4 hours old. So it's a
So my question is for Paul. Paul, always amazed by the images and the reconstructions you show of ferumoxytol MRA. I guess I'm wondering, in terms of your practice, cost, maybe patient experience with ferumoxytol are generally things that come up. How do you balance that in terms of when it's used and the general applications that you advocate to the clinicians for using it?
Yeah, we've done about, over 2,000 patients now, many of them several times over the years. And probably the most common indications in our practice are patients with renal impairment, for whatever reason, where clinicians are still reluctant, to do GAD, as Bob Edelman pointed out earlier on. Maybe not rationally, but they have an unease about gadolinium still. So we do a lot of those. We do a lot of patients with renal transplants for the same reason. And then patients with congenital heart disease, all the kiddies with congenital heart disease that we do MRI on, we use ferumoxytol and have done that actually for 10 years. So we've done hundreds, with the 4D music and 4D flow techniques. And as I mentioned, they're they never fail because you're in control of everything. Moving along from that, then, you know, once you say, all right, you're no longer fully in control of ventilation and motion, then all kinds of technical challenges open up. But now pretty much all of our adult congenital patients as well are requested with ferumoxytol. So we have all of these techniques and you know, advanced 4D flow techniques and advanced 4D breath held imaging techniques now. As I mentioned, ferumoxytol is also wonderful for improving 4D flow. I think it's going to make a huge difference. And you can use very aggressive accelerations, you know, under sampling factors of 20 or more, which is sort of, it's amazing, but it works. And then in general, quite honestly, I don't want to sound too hyperbolic, but for just about any vascular imaging given a choice, I would probably opt for ferumoxytol. You can, of course, do a great job on lots of vascular territories with the gadolinium agents, as we've done for many years. But you hit a ceiling at some point, and they're complementary. Ferumoxytol can pretty much be used for anything. For some things, you know, you have a limited time window with gadolinium, and if things get, you know, messed up, if something happens during the first pass, well, the first pass is unique. You've only got one of those. In the steady state with ferumoxytol, you have as often as you like, as long as you like, in principle. So often you might repeat a breath hold 2 or 3 times, and you might adjust your parameters. There have been times when, you know, patients have left the unit and it was discovered, wow, we should have looked at something else. You can bring them back a few hours later, and it's like they've just come in because the agent stays around for hours. So that's the scope. In terms of cost and reimbursement, it used to be very expensive. I thought they were going to, our administration were going to come down heavily on us because of this, but I never heard anything. And it transpires that in most cases, insurance covered it. And now, you know, what was very expensive, it used to be over $700 a bottle. Now that has been, you know, more than halved with the introduction of a generic version. And I think in the future, that will probably be halved again. So cost will not be a factor, I think, down the road. Sorry for the long response.
Very thoughtful and inclusive lecture. I did want to ask though, how did you get the stuffed deer to run? That was one. But no, seriously. But I do have a quick question for Paul. Paul, you're starting to show time resolved, meaning dynamic ferumoxytol. Where do things stand with that now, given the black box, the slow injection? Are we starting to be able to use this dynamically?
Well, I mean, I do this as we need to do it, Jeff. How you use these agents, once something is approved by the FDA doesn't tell a physician what to use it for or how to use it. And absolutely, there was this black box warning that suggested slow infusion. That's a good thing to follow. So do not ignore these directives or do so at your peril. But you take things in context. And if you feel, if it's in a patient's best interest to get a time resolved study, then you try to figure out, well, what's the risk? The risk is actually very, very low. The other thing is, you know, we used to bolus ferumoxytol for years before this black box warning came out. We never had any issues. I'm not saying go out and bolus, but also with ferumoxytol, the way it had been initially set up for therapy, it was set up as a 0.5 gram iron bolus injection over 16 seconds, okay? That was done purely for marketing purposes to show how much safer it was than all of the other intravenous iron agents. And, you know, it may well have been. It was designed to be bolus injectable. That's why, you know, the therapy people got so hot on it. And there were, you know, over 1 million injections with very, very little at that rate. For MR, if you inject 0.5 gram in 16 seconds, blackout, you're not going to see anything, right? So in fact, you should never, use probably on first pass more than maybe a quarter of that dose infused over 15 or 20 seconds. What we do for the time resolved is we use a dilute formulation, diluted about 1:6, let's say, and inject 10 cc's of that over 10 seconds. It's still actually a very, very slow rate of injection, but it's enough to give you a perfect time resolve study.
I would just like to add to that, the FDA has no jurisdiction over me in Scotland, but the FDA black box warning said not to bolus inject it. And as you know, Jeff, it's thick, tarry stuff. It's not nice looking stuff. But all the ferumoxytol imaging I've done, several hundred now, every single one, we've done dynamic time resolved twist imaging on those patients. And we give a small bolus first, 1 milligram per kilogram, diluted, and we never bolus it. We use a controlled contrast pump infusion injection, not a bolus. It's a controlled contrast pump infusion injection. And I'm sure that's what Paul is also doing.
Exactly the same thing as my lawyer said. But it's a very good point. It's still a relatively slow injection in absolute terms.
Any question?
So I would have a quick question to Giles. Reflecting to the interdisciplinary collaborations, how does it work in your institution? Do you have any scheduled meetings with, especially, I know that we have a closer connection with cardiology, but for example, SMMS University with the vascular surgeons, I feel like we could improve the communication and meet each other clinical needs. Do you have any experience with how to communicate with these other specialties? Thanks.
So for cardiology, I work with cardiology imagers as well. So cardiology imagers who do cardiac MRI, but also some that do cardiac CT, and they have lists of their own sessions and they report their own stuff. And, they'll come and tap me on the shoulder and say, what's this thing in the lungs? Should I do something about it if they're not certain? And on the vascular surgical side, we've had a vascular surgeon, Tricia Roy was at this meeting, but we have meetings every week. We have our multidisciplinary team meeting with vascular radiologists, such as me. I only do diagnostic now. I used to do interventional. Our interventional radiologists and our surgeons to discuss our cases. And several of our surgeons, they mainly do endovascular. So we have some surgeons who do endovascular aneurysm repair, though the majority of our endovascular aneurysm repair is done by radiologists, which is unlike the US, where most EVAR is actually done by surgeons. But a lot of surgeons now are kind of hybrid and they become radiologists. So some of our surgeons, they're very used to looking at PACS workstations, doing MPR and planning their procedures and things. And I think, it's difficult sometimes to differentiate, who's a surgeon, who's a cardiologist. And certainly when I go to British Society of Cardiovascular meetings, I forget, I've been seeing these people for many years and I forget which one's a cardiologist and which one's a radiologist sometimes. And it's bringing people together. And so, it's meeting people, going abroad, finding collaborations, and that breaks down barriers.
If I might just make one quick comment about that same thing. I mean, in my experience, sometimes with vascular surgeons, they like CT. And the reason they like CT is they can actually read the images and interpret it, and intuitively they have a good sense for it. They're far less comfortable about MRI and MRA. And, sometimes it's these, intangibles that can make a big difference in referral patterns. And it's not easy to know what to do about it.
Any other question from the floor?
Thank you so much. And thank you for our closing plenary speakers for the wonderful discussion. And now I'd like to invite Jeremy and Oliver to give us a summary of this year's meeting and to hand out the awards for the 2025 meeting.